Thanks very much, Jeremy. It's a real pleasure to be with you, and I've heard such great things about these meetings, and it's wonderful to see so many familiar faces and say hello to people. So yeah, Jeremy asked me to speak on antibiotic stewardship, and I think cases are the best form of of learning in this. I fully appreciate that people have different approaches to stewardship, and I'm not presenting here the absolute correct way of doing anything. Basically, I'm presenting what our practice is, my practice is, and I'm really happy to have a discussion and have anybody give different ideas. Just some ground rules. If you are going to ask questions, anybody who uses a trade name has to buy Jeremy lunch at the most expensive restaurant in Johannesburg. And Professor Pabas, if you use a trade name, you'll be buying me lunch for the rest of the year. So we're going to start. I don't have any conflicts of interest to declare, and this, just very basically, going back to square one, what do you have to think about when you are prescribing an antibiotic? And I'm going to talk about antibiotic stewardship, bacteria infections here today, not antifungals, other antimicrobials. And you'll all be very well aware of this list, but it's amazing how often this sort of thinking is either shortcuts are taken and people don't think about these questions. So the cases I'm going to depict are going to look at some of these issues. But just to say, why are we doing this? Does antibiotic stewardship in hospitals work? And this study, systematic review meta-analysis from Evelina Tacconelli's group about 5 years ago, showed quite well, demonstrated beautifully actually, that if you put in antibiotic stewardship programs in hospitals, it reduces the drug-resistant infections, both gram-negative and gram-positive. And that is augmented if you co-implement it with an infection prevention control intervention, particularly hand hygiene, with really marked reductions. So there is a point to this. Okay, let's start. I'm just trying to. Okay, so this is just a warm-up to get your fingers going. Everybody, please use the poll. It's, as Jeremy says, it's anonymous, and there's no wrong. Well, there may be a wrong answer, but there's no terrible wrong answers here. So we're warming up with the smoking plumber. He's a middle-aged man, and he's been ill for just under a week with a green sputum cough. Doesn't normally have cough. And he's got some right-sided chest pain as well. He's just mildly dyspneic on exertion. He didn't have a viral illness to start with. There's no prodrome. And he's got a temperature getting towards significance. He's not tachycardic, blood pressure's maintained. And he's got some wheeze and a respiratory rate, worse wheeze on the right around the area of his pain, but also on the left, and his white count slightly raised, upper limbs of normal 11. So he's got a white count of 14.4, and it's a neutrophilia. Okay, so question one. Which one of the following would be your management? So would you give him an outpatient fluoroquinolone? Would you give him amoxicillin or doxycycline? And if it's in the flu season, put in a bit of oseltamivir. Would you broaden the spectrum to amoxicillin clavulanate, amoxiclav, to extend some broad gram-negative cover? Given his history, he's a smoker, he's got chest pain, some mild dyspnea, would you admit him for IV antibiotics, or would you do something else? So if you could vote, please. Just going to give 30 seconds. Okay, so we are going to end the poll there. And the poll suggests that 2/3 of you would give outpatient co-amoxiclav to extend gram-negative cover. 20% of you, 1/5, want to give amoxicillin or doxycycline and add in some oseltamivir for good measure. 7% want to admit him for IV antibiotics. And even 2 of you want to give moxifloxacin, levofloxacin, a bit dangerous in TB world. And 5 out of 56 of you, so just under 10%, want to do nothing. So my answer to this would be E, do nothing, go give no antibiotics. Why? Because what I'm describing and what is described in this case is acute bronchitis, which, as you know, is a viral illness in over 90% of the cases. And it's defined as a relatively short duration of acute cough, but it can be up to 3 weeks, with normal vital signs and importantly, no signs of pneumonia on examination. Remember, he had some wheeze, mild wheeze, but he had no consolidation, no clinical evidence of consolidation. He had a SIRS response in terms of a raised temperature and a slightly raised white count. And 10%, less than 10% are, as you know, if it's very prolonged cough, particularly pertussis and some of the atypical infections. So Adrian Brink and some of the people on the call, on the meeting, and myself as well, we looked at appropriate diagnostic testing. Is there anything that could help in community? Patients presenting with acute cough, how do you tell the difference between community-acquired pneumonia and acute bronchitis? Generally, these are from the literature. These would be the factors, a high significant temperature, a tachypnea and tachycardia, and evidence of consolidation on examination, which this patient didn't have. And then a PCT, point of care PCT, has been used in some of the community scenarios. Levels do differ on action, but generally if you've got a very low CRP, pushes you more towards acute bronchitis in those areas of diagnostic uncertainty. If you've got a higher CRP of greater than 100, then you'd look at the severity assessment for CAP. And certain patients with acute bronchitis, if they're very old, I mean over 80, or those over 65 with specific issues that are listed in the little table on the right. And so point of care CRP, which is not very present in South Africa. And one of the problems, as you know, is that private medical aids won't pay for point of care tests. So it's out of pocket. Most people wouldn't want a CRP, or wouldn't pay for a CRP, but it can be useful. And again, as you know, there've been large randomized controlled trials of using CRP with other interventions in the community, and particularly in GP practices in Europe, which has shown safe withholding of antibiotics for viral illnesses. Okay, so before going on, Jeremy, I mean, I can't see anybody else and I can't see hands up, but I think this is always a very useful one to start with, because it is a community-acquired infection. Appreciate acute bronchitis, but these sort of poll variations are actually fairly common in most people you speak to. And again, as you know, acute bronchitis is really probably the leading cause of antibiotic use, of perhaps unnecessary use in the community. So I think it was a good one to start off with. I mean, the other thing is just to say around the answers, I mean, oseltamivir as an outpatient, even in the flu season, has relatively little role, particularly because people generally present too late, and it only reduces symptoms overall for mild influenza-like illness for a matter of hours. Extending spectrum for co-amoxiclav to give gram-negative cover and some anaerobic cover, even if this was a community-acquired pneumonia in a 43-year-old a smoker who's relatively fit well. Otherwise, I wouldn't personally use comoxiclav. I don't think that's necessary, and obviously the collateral damage is significant in terms of C. diff and selection out of other resistant bacteria. And then admission for intravenous antibiotics, again, in a patient with no clinical signs of pneumonia, I really wouldn't suggest. So that would be my position on that case, on the first case. Jeremy, is there anything anybody wants to interject on, or can I go on to the second case?
Yeah, I think let's go on to the second case. Good stuff.
Okay, so 2/3 of you, let's go. Time to do another one. Okay, so a confusing problem. This is an older lady, 82. She's got known dementia, and she's in a long-term care facility. She's bedbound, admitted off her baseline. Very common scenario that we get in, as you're aware, in medicine. More confused with a temperature 37.5 to 38 over the last couple of days. And on examination, she's got a GCS of 14, she's disorientated. Again, she's cardiovascular, apart from a soft, what was thought to be a non-radiating ejection systolic, aortic sclerotic murmur, but with normal blood pressures and normal character of the pulse, suggesting that she probably didn't have significant aortic stenosis. Her respiratory and abdominal signs were negative. She didn't, the intern didn't examine the rest of her systems, and including her neurology. And she too has a slightly raised white count, 13.6, normal, just a sort of lower limit of normal around platelets. The rest is normal apart from a creatinine of 103, and she had blood cultures and urine culture sent. On her urine culture, she grows a OXA48 Klebsiella pneumoniae, a significant growth, greater than 10 to the 5 colony-forming units. Really a nasty bug, resistant to carbapenems, with high MICs and resistant to a whole set of antibiotics, really only sensitive to colistin, but around the MIC of the breakpoint colistin, but thankfully sensitive to ceftazidime avibactam. So, a confusing problem, which one of the following statements or one of the following management actions would you take? Would you A, start colistin using a loading dose, followed by 4.5 million units, 12 hourly, but adjusted to renal function? Obviously, she's got slightly, you don't want to know her EGFR. Would you withhold the loading dose because of this mild renal dysfunction and use a maintenance dose? Would you give the loading dose, and as you would for A, but would you add meropenem, high dose prompt infusion for combination therapy? Would you call that charming Dr. Nell and ask for 40,000 rands worth of ceftazidime avibactam, which I'm sure he'd pay out of his own pocket just to please you, or would you do something else? Let's go. If you could vote, please. Oh dear, it's gone to the next stage. Right, well, sorry, that was my bad. Okay, I'm going to end the poll there. Before I gave it away, sorry about that. Clearly, you guys are starting to have been burnt once, and you're a bit wary of what I'm after. So, Jeremy, can you see the poll results? It says share results, which I've clicked. I don't know if you can see them.
Oh, briefly, yes, it stopped sharing now, but it was about. I can show it again. 68% option.
Okay.
And then 10% BNC.
So 10% want to give colistin. Gosh, 6 of you want ceftaz avibactam. Lovely. So Jeremy, 6 of you for 40,000. Yep, that's it's a goodly amount out of pocket. So yeah, the question is, this patient is confused. She's elderly. She's off her baseline, which is an incredibly common presentation, and it's often put down to urinary tract infection. And she's clearly got bacteriuria, but does she have a urinary tract infection? And in fact, her white count in the urine, there were no white cells in the urine, which makes urinary tract infection extremely unlikely, even in an elderly patient like this. And the examination, as I said, wasn't done properly. But unfortunately, when the patient was examined, she had a large DVT. So both of these cases talk to that first really initial statement around antibiotic stewardship, about what we have to think about. Is there a bacterial infection that requires an antibiotic? And what I've shown here are two of the sort of big pitfalls, the particular pitfalls around the misuse of antibiotics with viral infections, respiratory viral infections, and then whether you've got a colonizer or whether you've got an infection. Now, this was from the SASP Handbook that Sean Wasserman and Tom Boyles and I produced many years ago, and it just basically gives an idea of the pathways to think about. If you do get a positive culture like we've got, is it from a sterile site on the right? Obviously, you're not meant to have bacteria in sterile sites. If the organism doesn't fit the clinical picture, it's more likely to be colonization. You've got to think about it. Is it an enterococcal infection of the colonization of the urine from poorly taken sample? If it fits the clinical picture, it makes it more likely to be. And then also for the non-sterile sites, again, is it normally present, an organism like this, or not? And then you can go through the algorithm. But it's important to think about colonization versus infection. And long-term care facilities, that's the archetypal place where urinary tract infections are overdiagnosed and overtreated, and asymptomatic bacteria is incredibly common, both in men and in women, and particularly the incidence of new episodes. I mean, 10% in this big American study, 10% of non-bacteriuric men became bacteriuric within every 3 months. And again, per women year, there's a high rate of asymptomatic bacteriuria. And only 10% when you looked at febrile episodes where there wasn't localizing findings. And I appreciate that can sometimes be difficult, of course, because of, if there is dementia or other things, but in these large studies where there wasn't localized signs, then the true bacterial infection, urinary tract infection, was very low, and the positive predictive value of bacteria was only 12%. So urinary tract infection continues to be the commonest indication. And when you look at meta-analysis, systematic reviews, you can't do meta-analysis because the level of data is so poor. So although a number of individual studies conclude that there may be a link between UTI and delirium, for example, the methodological flaws are just so poor, they're biased. And in this big systematic review from a couple of years ago, in BMC geriatrics, again, you can see that they were able to do some qualitative work, but they weren't able to do a meta-analysis. So I think the jury's very much out, but I think the bottom line is that we overdiagnose urinary tract infection in long-term care facilities, and particularly in patients coming in confused or off their baseline in our emergency units and departments of medicine. And one has to really think very, very carefully about whether this is an infection or not. Jeremy, I think I'm going to go on to case 3, unless there's comment.
It sounds good.
Okay, so Mr. Shortchanged. This 58-year-old man who's had a knee replacement 18 months previously was admitted to St. Elsewhere, where he had signs of an infected joint. There was a sinus. He went for a washout and biopsy. Was started as per protocol there with kefazolin, 8 hourly, and a culture of an operative swab grew both Acetobacter baumannii, which there was some sensitivity, thankfully, to tigecycline, amikacin, and colistin, and Enterococcus faecium, sensitive to vancomycin and linezolid. So if you'd like to vote on the following, would you cover both, starting vancomycin and tigecycline? Would you withhold the tigecycline because of the low virulence of Acetobacter baumannii and just treat the faecium? Would you start amikacin and tigecycline combination for the baumannii, but withhold ampicillin as faecium is an unlikely pathogen for PJI? Would you start linezolid rather? Would you stake away from vancomycin because of the amikacin and just use linezolid? rather than vancomycin for better bone penetration? Or would you walk the walk of shame and ask the orthopod what she'd do? So if you could start answering. Okay. There were 59 people on the first one. So there's quite a few people not making their minds up. If the 20 or so other people could vote. In fact, only 27% have voted. There's no problem. It's all anonymous to the people who haven't. Are they still able to vote, Jeremy, or not?
Sorry, I just stopped it now so that they can't anymore. But yeah.
Oh, okay. Shame. Okay, so half of you will walk the walk of shame. Sorry. A fifth of you, 17%, are going to start amikacin and tigecycline combination. 11%, 4 of you want to start vancomycin with holder tigecycline. 3 of you want to start vanc and tigecycline. And D-Lin is 11. So half of you are going to walk the walk of shame. Okay, that's great. So first of all, when you are taking biopsies for suspected prosthetic joint infection or a chronic osteomyelitis, never send one sample. The Oxford group, sorry, I'm not sure why that forwarded. Sorry, there's some silly buggers going on. So the Oxford group have a bone infection unit, done a lot of work on this. They showed that you need at least 3 or more independent specimens for prediction of infection. And their recommendation is to take 5 specimens for a cutoff. And you want positivity in more than 3 or more. Jeremy, I'm really sorry, I'm not sure why this is going backwards and forwards, but this is a slide taken from Matthew Scarborough's talk at ECMID last year, just to show what orthopods need to do these biopsies. So it's really important that you do individual biopsies with individual sets of equipment. You mustn't cross-contaminate, so they shouldn't use the same equipment for each of the biopsies. So you want 5 separate labeled deep samples. So it doesn't pay to be stingy and do just one. You would walk the walk of shame and ask the orthopod what they do, and she does, and that would be the biopsying 5 times. Return to theatre this patient, and 5 biopsies were taken. Bowel mono wasn't found on any of them. 4 fecium was found, and there was 1 contaminant, thought to be contaminant, coagulase negative staph. She was started on vancomycin, demanded to go home, so was switched onto the only orally available drug. So here we're talking about having realized that there is an indication for an antibiotic. Antibiotic stewardship demands that we then send appropriate cultures. And you've got to be careful about what cultures you send and how you send them. You know, Tom Boyles did some work here previously showing that if you take blood cultures, and if you take less than 8 mils versus 10 mils into the blood culture, you double your yield at 10 mils. So, you know, the way you take blood cultures, where you take cultures and what you send is very important. What about swabbing? Often asked about when to swab. The answer is almost never. In burns units, they usually are swabbed on admission and then do some surveillance swabbing. As you know, burn infection needs to be diagnosed from tissue. So you're looking for greater than 10 to the 5 CFU per gram of tissue. So you're looking at biopsy. So if you did suspect infection, you would biopsy rather than just swab. But the swab does give some important information about the epidemiology of resistance in a burn unit. But otherwise, so often we are sidetracked, or people are sidetracked by wound swabs. We had a case here some years ago, classic case from George Hospital, who was sent with a swab with a almost pan-resistant, only colistin, I think, Acetobacter baumannii from a swab of a bed sore, and was sent all the way from George to Cape Town for colistin, and was unfortunately sent all the way back very quickly. So don't swab outside of a joint. Okay, Jeremy, I'm going to go on unless you tell me, otherwise I'm going to go on to the next case. So we've done.
Sorry, a couple of questions in the chat. One was about the utility of removing the prosthetic knee, so the prosthetic material, and then another question was about the orthopedic surgeons apparently often quoting the requirement for multiple samples as washout samples. Is that a fair interpretation? In other words, versus the equipment that you seem to show on the slide.
No, we wouldn't use washout samples. I mean, if there is a joint infection, prosthetic joint infection, and you should have bone samples, and well, often one's a swab, so there may be pus, but we try and encourage at least 4 and generally 5 individual bone biopsies. The removal of the prosthesis is obviously, there's a question about that relates to the surgeon and the particular type of infection and the timing of the infection. So, but in general, we try and keep the joint intact as it was, and treat the infection with antibiotics rather than removing the. But I mean, practice will vary, not only centre to centre, but from surgeon to surgeon.
Great, thanks.
Okay, so is there an indication? Yes, no. Is there colonization or infection? And secondly, have you sent your samples correctly? And I'm sorry, I know this is obviously an ID audience, and I know it's basic, but the amount of times this is done wrong, even by ourselves, needs us to remind ourselves. Okay, so the agony of choice, number 4, a young pedestrian vehicle accident. She's got an anterior tib-fib fracture. Again, very little between the skin and the bone. She's admitted for a debridement and has to have an external fixation. Day 12, wound infection, debrided and biopsied, and started on Kefir. And 3 of 5 biopsies, this time taken correctly, grow Staph aureus, and it's pretty sensitive, apart from resistance to penicillin. And she started on flucloxacillin at 1 gram 6 hourly. So, what are you going to do? Do you A, convert to intravenous cloxacillin for 2 weeks and then follow up for 4 weeks of fluclox? Do you B, continue fluclox for 6 weeks? To complete treatment? Do you add in rifampicin for the 6-week course with flucloxacillin? Do you switch to cotrimoxazole for 6 weeks? Or do you convert to rifampicin, 600 milligrams for 6 weeks? So if you could vote now, please. Okay, so about are you sharing the results, Jeremy?
Yes, yeah.
Great. Okay, so you're split about 1/3 each, wanting to give IV clox and then 4 weeks of fluclox, and 1/3 of you want to just continue flucloxacillin for 6 weeks. About 10 of you want to give fluclox and RIF, and almost none of you want to convert just to RIF, that's just 1, and about 10 of you, a fifth, want to go to cotrimoxazole. Okay, so what's the question here? Well, having an indication for the antibiotic, knowing that you've taken your samples, your choice of antibiotic is next. And there are many factors that determine which choice of antibiotic you want to give. One of them is obviously penetration to the site of infection. And is the antibiotic you're choosing good for that site? Now, there are, as I said, there are obviously many different factors. There's the drug itself. You may, for urinary tract infection, some people like to use quinolones because you can reduce duration. Some people won't use aminoglycosides for bloodstream infections. I don't agree with that, but some people feel they shouldn't. So it does, you do have to think about this. So, and in bone infection, again, I'm sorry to have the same tissue, but for bone and tissue around the bone, it's very important to know about PK data. And again, this is from Matthew Scarborough's talk, but it's a nice indication of the bioavailability of different antibiotics. And as you can see, we don't use flucloxacillin for bone infection or joint infection. We find it's got very low penetration, and we've seen some failures. Cotrimoxazole is generally very good. Rifampicin is a good drug, as you can see, in terms of tissue concentration, but a number of studies with Staph have suggested that monotherapy with rifampicin is higher rates of failure. It's associated with higher rates of failure. Rifampicin does come into it, as you know, for biofilms. So if you've got prosthetic joint infection, then we would start rifampicin with another drug. Now, the important thing to know there is to not start that until the wound is completely closed. If you start rifampicin in prosthetic joint infections or osteomyelitis with an open wound, then the resistance that occurs to rifampicin in skin flora is transmitted taken into the wound very quickly, and you set up a resistance in the wound. So we generally wait until all drains are out and there's been closure, and we would then add rifampicin if we needed for biofilm. And then again, in gram-negative infections, biofilm, you want to use quinolone. Ciprofloxacin is a very good drug used here and elsewhere in other countries, and has a very good penetration into biofilms. So the correct answer here would be option D, which would be, to me, the correct answer, sorry, would be option D, but others may have different feelings on this. Okay. Jeremy, I'm going to continue. So indication, cultures, choice of drug, for site, for penetration, and for all those different factors. So now, failure to thrive. This is a young man, as I'm getting towards his age. He's a young man, admitted with a stroke and a bulbar palsy, and developed fever, tachycardia, and hypotension on day 6 of his admission. He was started on hospital-acquired regimen, piperacillin, Acetobacter, amikacin, and catheterized. And the catheter sample, with a fresh sample when he was catheterized, grew an ESBL Klebsiella, sensitive to ciprofloxacin. The blood cultures were negative. He was de-escalated to enteral ciprofloxacin after 3 days. And 3 days after that, he went into septic shock and required inotropic support. You examine him and his drip sites are all clear, normal. There's no clear source of new infection and no diarrhea. No evidence he could have C. diff. And there's no significant change radiologically. He underwent a CT abdomen to ensure they didn't have a perinephric collection. Just as an aside, we find that you need CT really to differentiate, to tell a perinephric collection to really rule it out. Ultrasound, we don't find quite as beneficial. But the CSU taken at the time his clinic deteriorates, the white count obviously is in the urine is uninterpretable because he's catheterized. We expect white cells in catheterized patients, but he unfortunately is growing the identical ESBL Klebsiella pneumonia, which is still sensitive to ciprofloxacin. So what would you do now? And has this happened? So Jeremy, this isn't a poll, but maybe you want to ask one of your whoever you think would like to answer this.
Yeah, sure. Which of our happy fellows would like to take a stab at this? I've got. Okay, I'm gonna pick you, Lyle, because Lauren's doing the next bit. So, what would you do in this case? I've allowed you to unmute.
Well, in this case, we know that he's colonized, at least with this ESBL, Klebs pneumonia. He may have, he's now shocked, he's got hypertension. You can't be sure that he's at least getting decent levels of his Cipro orally anymore. So I think at this point, we haven't cultured anything else. We know he's colonized with it. You'd maybe want to give him IV Cipro at this stage, and obviously culture him, see if he's actually cultured anything else possibly as well.
So why do you think he's still Cipro sensitive, and despite Cipro, he's gone into septic shock? Why do you think it's happened? He wasn't in critical care. He was on the ward with a stroke.
Well, I'm not sure if he possibly didn't have his catheter removed at the time.
Wasn't yeah. No, he didn't have his catheter removed. He's still got the catheter, you're right. So you think it's because he's catheterized?
Well, he hasn't had any, well, we haven't really gotten to source control.
Okay, but he doesn't have a collection. Yeah, it's difficult. I mean, obviously you don't, this is all slightly set piece and a bit, there's other things you'd obviously do and look at. So, it's not really fair to ask, but that's interesting. Yeah. I mean, even with somebody who's catheterized, there's no obvious collection, is sensitive to ciprofloxacin. Ciprofloxacin's a great urinary antibiotic. You'd sort of expect it. Okay, so we talked about, thanks very much. We talked about, is an indication. We talked about how the culture's been sent. We talked about defining which drug you want to use, but there's no good using a drug, even if it's the right drug, if it's not getting where it needs to get to. And the reason it's not getting to where it gets to is because this guy's had a stroke and he's enterally fed. And if you feed, if you give ciprofloxacin enterally through an NG tube, and they're being fed at this as well with oral enteral feeds, it reduces the bioavailability of an absorption of ciprofloxacin, and it can drop up to almost by about 2/3. So we had a couple of these cases until it clicked. Should have clicked after the first one. The other important thing is that using doxycycline with an NG tube, it actually sticks to the tube. And that's been a problem in cases of severe rickettsial infection where we wanted to give doxycycline and one couldn't give it down the NG tube. So again, it's a bit of a trick case, I'm sorry, but again, these are sort of things that one needs to think about. Is the antibiotic getting to the site of importance? And this really talks to, when you've got the right bug and the right drug and the patient's deteriorating, is it something else? Of course, we do see that, it could be a PE, it could be, whatever. Is it the fact that there is a lack of source control, which, as you said, quite rightly, that's the number one thing we think about. Is there collection? Is it source control? Is the patient actually getting the drug? And are they absorbing it? So this talks to the route in particular. Is the route correct for the infection that you're needing? We're all very happy with drugs we have to give IV in certain circumstances like meningitis and myocarditis, but these smaller things actually are important too. Just a note on the quinolones, really avoid it, leave the Queen alone in her platinum jubilee. She's actually got her fingers crossed here, by the way. It's not what you think, but lots of black box warnings around quinolones. I haven't shown the tendon rupture, which is one of the concerning things in the elderly and in diabetics and young athletes. But there's also this black box warning around aortic dissection. We know that ciprofloxacin, although a great urinary antibiotic, decimates the gut microbiota, whereas, for example, nitrofurantoin, much less. It's not concentrated in the gut, so nitrofurantoin is a great urinary antibiotic, as are the minor glycosides. We know that they drive carbapenem resistance if you've had prior fluoroquinolones, C. diff, and MRSA. So leave the queen alone. Okay, nearly at an end, bursting to make a decision. A 72-year-old woman with peritonitis, cecal mass had perforated, a drain was left in situ, she had a hemicolectomy, anastomosis, and she was started on co-amoxiclav intravenously, and the drain was removed after 48 hours. Her temperature is resolving by day 4, and she's taking oral feeds. So in this scenario, would you A, complete 2 weeks of intravenous co-amoxiclav, complete 7 days of IV and switch to oral to complete 10 to 14, whatever your preference? Would you switch co-amoxiclav to oral as soon as she's eating and stop antibiotics, completing day 4? 48 hours after sorry, having a technical problem there. D, would you switch to co-amoxiclav and stop 48 hours after her SIRS criteria have resolved, or would you switch co-amoxiclav to oral and stop whenever she leaves the hospital? If you could vote now. Okay. Okay, so the overwhelming favorite is option D, switch co-amoxiclav to oral and stop 48 hours after fever. Another SIRS criteria resolved. Just nearly a quarter of you want to stop at day 4 at oral once she's eating, and a fifth of you want, 16% of you want to complete 7 days and switch to oral for 10 to 14 days. Okay, and very few of you want either A or E. Okay, so this talks to, having gone through all those issues, you now want to know about duration. And it's important to know durations, because the less antibiotics we give, obviously, the less duration of treatment, the less likely you are to select out resistance. And the correct answer here relates to switching is C. So 16 of you, 22% had the right answer. I think those that answered D are probably throwing their hands in the air and howling at the moment. Yes, that's fine. But this is based on some evidence. So this was the New England Journal trial 7 years ago, where it talked to when it was safe to stop antibiotics with a patient who has intra-abdominal infection but source control. And they looked at 4 days of antibiotics versus antibiotics until 2 days after resolution of SIRS. And they found, looking at composite endpoints, that there was no difference in either the 4 full days or until 2 days after resolution of SIRS. And just to be quite clear, patients at 4 days in the 4-day group stopped even when they still had temperature or some raised inflammatory markers like a CRP. So in this situation, in an abdominal infection where there is source control, in this scenario, 4 days is okay, and you would stop in this scenario. In many different scenarios, when we don't really know the site of infection, or there's a question mark around it, we do go by the sort of 48-hour rule but in certain set piece certain piece infections, you can get away with the evidence. I'm putting this up mainly for the trainees. Brad Spellberg's done a lot of work on this from UCLA, very interested in Shorter is Better campaign, and the website is shown here. And there's a lot of trials now have shown equal outcomes, so non-inferiority of short versus a long course. Interestingly, if you give people a range, they almost always will go for the longer duration, so try not to give a range. Older prescribers treat for longer. So unfortunately, those of us getting a bit long in the tooth tend to go longer. But there's some really important data here, and I would push you towards it. Okay, I think the last case is the man shot at the last chance saloon. In fact, these are two very quick cases. A 22-year-old man sustained a gunshot abdomen, perforating his colon and a biliary injury, had a left hemi, given coamoxiclav for 5 days, preventative treatment because he'd had spillage into the peritoneum. Complicated at day 10 with a HAP, and empirically treated for 14 days for some reason with meropenem. With HAP, we usually go with 7 days on the evidence. And then further febrile episodes occurred with increasing inflammatory markers without a clear focus. He had a CT scan which showed a subhepatic collection, and a pigtail catheter was cited and a pus sent for culture. And this was the culture result. He basically had a pan-resistant Acetobacter in relation to the drugs that we had available, including very high colistin, MIC, and he basically had nothing that we could offer. Today, I've just put this in 5 minutes before the call because today we had word of a patient, a young man with aplastic anemia who had not been to healthcare before, presenting for the first time, rectal swabbed and had a CRE. Despite the resistance profile, he was treated neutropenic fever with those drugs and deteriorated on day 3. And a blood culture from that day showed the most resistant Pseudomonas we've seen, resistant to everything, including ceftazidime-avibactam and ceftolozane tazobactam with high MICs. So this is really, truly a pan-resistant Pseudomonas. And basically, both of these cases, there's not a poll for this. I'm just going to briefly, in the last 5 minutes or 10 minutes, talk about what we do when we're here. For those of you that don't know this program, I really suggest you get to know it on Netflix. It's one of the great comedy series with Eugene and Daniel Levy. So we're talking now about difficult to treat resistance. I think that's what the terminology we need to go to now, rather than talking about MDR and XDR. Really, this is the new frontier of the new battle. I don't like battlegrounds because it's not a war, but it's the frontier. These are infections that are resistant to all first-line beta-lactams, including the beta-lactamase inhibitors, first-generation beta-lactamase inhibitors that we've got, and fluoroquinolones, and there may be varying resistance levels to the aminoglycosides and other drugs. In fact, in this fairly large study by Kadri, published a few years ago, they looked at over 45,000 blood cultures in over close to 30,000 patients, and found that there were 1% fell into that category of difficult to treat resistance, and predominantly they were Acetobacter baumannii, and not surprisingly, the risk factors for DTR, the main one was Acetobacter with a adjusted relative risk of 7.9. And then co-infections and hospital-acquired infection, prior bloodstream infections. And you can see in the bottom 2 graphs, mortality differential between difficult to treat versus carbapenem resistance, extended cephalosporinase resistance or fluoroquinolone resistance, an adjusted risk ratio 1.4, and then sorry. Also, if you had the number of active drugs other than in DTR, in other words, if you had a aminoglycoside or tigecycline or something, if you had none, again, your risk, understandably, your risk ratio was much higher. Carbapenem-resistant Acetobacter, like this patient, a really horrible bacterium with really problematic because of these multiple different resistance mechanisms it's able to call upon, and really a very concerning profile. Just to touch on the sort of newer antibiotics that we're only starting to really get used to. Kefir is available apparently in South Africa, but it's certainly not being used, as far as I know, in the public system. It's a new Cydra 4 cephalosporin, which I'll come on to, and is particularly interesting because it has activity against all the AMBLA class, including the metallo-beta-lactamases, and can be used for multi-drug resistant Pseudomonas. I've put can be used for multi-drug resistant Acetobacters. I'll show you that's a bit concerning at the moment from some of the data on mortality in the studies. Tolerazine tazobactam is really a predominantly pseudomonal drug. Keftaz-Avi covers class A and class D, so the KPC and oxa-48s, and then a variety of different combinations, most of which we don't have, certainly in the public system. I'm not sure if meropenem valbrobactam is being used. These studies have the problem with assessing these drugs is that most of the trials are poorly powered. They're only powered for non-inferiority, so they don't really show whether they benefit over the comparator. Most of them, comparators often carbapenem, and the breakpoints obviously takes time for breakpoints to be understood well, and exorbitant cost, which I'll come on to. Another new kid on the block, which you'll start to hear about now, but is not available yet, is again intriguing, Kefir taniborbactam. Taniborbactam has a boron backbone and is again usable against all the AMBLA class carbapenemases. So it's a very intriguing drug, and there's just been it hasn't been published yet, but the Venatorex, who are working with GARD-P on Kefir taniborbactam, have just released some early data from their phase 3 trials, again showing non-inferiority to meropenem in complicated urinary tract infection. People are starting to use ceftazidime-avibactam, unfortunately not always correctly. It's expensive. It was 80,000, but apparently you can now get it for 40,000 for 7 days. It's a new type of beta-lactamase inhibitor. Importantly, it's not active against metallo-beta-lactamases, Acetobacter baumannii or Pseudomonas. And equally importantly, if you're using it in complicated intra-abdominal infections, it has poor anaerobic cover and must be used with metronidazole. One of the cases here that did badly was being used without metronidazole. It's approved across the normal sort of drug approval trial scenarios that you'd expect, and has non-inferiority success against comparator in a lot of trials. There is interest in its use because of its seeming superiority for KPC, Klebsiella pneumoniae. Sorry, Jeremy, I am almost finished. And there's interest combining it with aztreonam, the monobactam, for metallo-beta-lactamase producing strains. There is, however, great concern of the speedy emergence of resistance to ceftaz-avibactam. In this relatively small study, in 37 patients, microbiological failures and high MICs were seen, detected in 30%. This is not to be shared on Twitter or elsewhere, but thanks to Chetna for this data, showing that in private in KZN, in the Lancet laboratory data, there's already significant resistance to ceftazidime-avibactam, and particularly concern in Serratia marcescens. So even before the drug is being used in the public sector, we're almost starting to lose it. A quick word about Tolerazine tazobactam. I believe it's still unpriced here. It's very good against Pseudomonas in general. That's its real niche market, and stable against AMP-Cs. Again, not good, not active against for Acetobacter baumannii or Pseudomonas. And there have been failures with high MICs. Again, the issue about resistance. Kefir is this new Cydra 4. It's unbelievably expensive. We had to look at it for this patient we were looking at this morning with aplastic anemia. We're quoted 50,000 for 2 days. It's about the quote I got previously was 110,000, making it unaffordable in public. The big concern from credible CR is that there was a high mortality, possibly related to carbapenem-resistant Acetobacter baumannii. So again, just how good Kefir is going to be with crab infections is a big question mark. So what are the options for difficult to treat? There's still the old colistin plus or minus a combination. I think particularly if you've got severe disease and MICs, to meropenem lessinate, colistin plus meropenem, otherwise an alternative, or colistin alone. Ceftazidime avibactam plus or minus aztreonam does have its role, but it's being misused. Kefir, not for Acetobacter, I don't think at the moment, if you can get your hands on it. And everacycline is a fluorocycline in the sort of similar to the tetracyclines and tigecycline. Again, resistance has already been shown with the TET mechanisms and TET binding sites. So there are some options, but we're losing them possibly as quickly as they're coming out through questionable use. So just to come back to finish this, it's simple, it's maybe banal, and maybe you think this is for other people, but this is where the mistakes occur. And I hope that some of these cases have been instructive in just thinking about some of the more minor issues or more detailed issues about antibiotic stewardship. So I'm going to stop there, and thanks very much.
Great. Thank you very, very much. It's always a pity on these Zoom calls there's no applause button as long as we get close. But thank you so much. That is an incredible sort of tour de force and a wonderful overview of a really, really important topic. I see in the chat Warren Lohman's mentioning that he says that Ceftolozine tazobactam will be around about 4,000 Rand a day, which is roughly the same ballpark as Ceftaz avibactam. But I mean, it speaks to your point, Mark, is that none of these new drugs are particularly robust, in the sense that they are, while their spectrum of activity is very broad, the resistance appears to develop pretty rapidly to them. And without the sort of infrastructure of good stewardship around it, they're going to be gone very, very soon. I mean, I don't know, you've been doing this a lot longer than I have, and you've been closer to the ground on this as well. But to me, although for 30 years people have said we're going to run out of antibiotics, we have always managed to keep at least half a step ahead. But this really does feel different now. I mean, we are rapidly running out of every possible agent, at least in my impression. I don't know if that's yours too.
Yeah, look, I mean, it's a spectrum, as you say. I think drugs like Kefir are interesting because they have it has a novel entry mechanism. The beta-lactamase inhibitors are all well and good, and they have better spectra, but I think they're, again, very wobbly in the face of developing resistance. It does feel different. I mean, I've watched this now, I guess, for the last sort of 13 years or so, and when I took up this post here in 2007, our hospital-acquired infection protocol was ampicillin amikacin, and now it's piperacillin tazobactam amikacin or a carbapenem, but it's rapidly going to need to change. I mean, in the last year, we amputated 4 limbs because of untreatable prosthetic joint infections with different types of bacteria. So it wasn't in an outbreak situation, and they were mainly from having been imported from elsewhere. We've had major outbreaks in 2014 2014, I think 10 people died of almost pan-resistant Pseudomonas on the bone marrow transplant unit. We've had further outbreak. We had a big crab outbreak in COVID. And yes, I mean, the problem is that we aren't one step ahead anymore. If you look at the pipeline, CARB-X are the sort of early pipeline generating. They've got a lot of very interesting molecules, but as you know, very few of those will ever make it to market. And majority of those are not unique and new modes of action. So it is incumbent on us to try and work this out in a better way. And I would finish by saying that it's a bit like TB. What do you invest in? Do you invest in treating MDR and XDR, or do you invest in getting it right early on? And the problem is that so many in hospitals, so many of these really horribly resistant bacteria are selected out by misuse of antibiotics early on. So that first question, is there an indication for an antibiotic, is absolutely critical. And that's where most of the time it goes wrong. And even small amounts of doses of antibiotics in the emergency unit, when it's clearly not necessary. We had one fatality 3 years ago on a single dose of Kefir. So a young HIV stroke patient died of C. diff and bowel complications from a single dose where he absolutely didn't need the antibiotic. So yeah, let's try and optimize things and not use antibiotics when we don't need them.
Thank you very, very much again. We're going to leave it there, I think, just in the interest of time, but thank you so much for those in the audience, especially the 6 people who are costing me 240,000 Rand for Acetobacter. Please see me afterwards, but otherwise, please do watch this again. We'll put it up on the account and make sure that at least for these examples that Professor Mendelson's gone through, that you're all familiar with it, because there's a lot to learn. I've certainly learned something from today as well, and there's always ways to improve, but it really is urgent. I mean, this is a disaster waiting to happen, and as Mark says, by the time the state gets access to many of these newer drugs, they may already be gone, given the barriers to getting them in the state early, and given the rate at which resistance is developing. So thank you very much, Mark, for your time. Hugely appreciative, and all the best. And everyone, please do take heart from this, and hopefully we can all do a little bit better and get away a little bit out of this mess that we're in.